since always. Because earlier on, smoking the chulha we burn, that gives you to most of the Indian ladies and public in general. Now we got the new challenge of pollution. It is not only so it's not only been a problem in India. Even in the UK, during the Industrial Revolution, there was a great London smog, which caused COPD in so many people, and there were deaths. But they made legislations which improved the situation, and now it's one of the cleanest place for breathing. So COPD, which is the outcome of modernization more nowadays, rather than the cultural thing of chulhas and all, needs to be addressed very well. So we've got a wonderful pair of speakers who will be speaking on the methods you can control it. One is by the newer molecules, and other is by another particle which is deep inside the lungs, very far inside, and helps you clear everything. So
yes, sir. ये लाइट
Hello, good evening everyone. Since we are a little bit late today, so I'm directly jumping to my topic. So it's a different day today, since we are celebrating or we are educating the entire the world population about the COPD. What is the COPD? So the theme for this year's COPD is whenever you are having breathlessness. It's definitely for the patient. So whenever you feel shortness of breath, you are feeling breathlessness, think about COPD also. So from the earlier background, for the last medical history for the years, it's been that whenever patient is feeling breathlessness, they always think about the cardiac opinion. So they always think about the MI, they always think about the heart failure. So that's why the gold society, the gold guidelines, they made all the recommendation treatment modalities about the COPD. Talking about that whenever you feel breathlessness, think about COPD also. Because why COPD? Because COPD is the leading cause of the mortality, much higher than the CHF, much higher than the MI. So that's about the educating on this COPD day. So in my presentation, I will try to be very crisp and short, and try to finish my talk in just 20 minutes. So I'll be discussing about how we manage COPD, how we diagnose the COPD, and what's the treatment strategies for the COPD via highlighting the 10 questions. Okay. The first question is what's the definition? So definition of the COPD, we all got confused about the COPD and the asthma. So the basic difference between the COPD and asthma is the COPD is the symptoms are the same. Cough, expectoration, and the breathlessness would be always in the asthma also. But the main difference between COPD and asthma is that you can see that asthma is a variable expiratory airflow limitation. Means there will be variability. There will be some days that the patient is totally asymptomatic, and there will be some days that patient is having just out of the breath. So that's the main difference between the asthma and the COPD, and that's how we diagnose asthma versus COPD. So in the asthma patient, Sometimes almost 10 to 50% time patient will be shortness of breath, but in the COPD the disease is persistent. The airflow obstruction in the spirometry we get, it's almost persistent. The first question is how to diagnose COPD. So the clinical spectrum is same like the COPD and the asthma. So the presentation would be, there would be breathlessness, there would be dyspnea in our terminology, in the patient terminology it would be SOB or the breathlessness. There would be chronic ongoing cough, there would be on and off wheezing, there would be some history of off and on respiratory tract infection. The same thing, the same story which is in asthma also. So the main difference I want to highlight here is that how we differentiate between the COPD and asthma and why it's important. So first thing is the clinical history. The patient is coming to us and based on the clinical spectrum we are suspecting that the patient is having some trouble with the respiratory condition, not the cardiac condition, because there is some symptom of ongoing tendency of respiratory infection and ongoing expectoration also. That's not common with the cardiac wheezing or the cardiac breathlessness. The second thing we diagnose or we label as the COPD is based on the spirometry finding. So in the spirometry you can see that the first graph, that is the flow and volume curve. So here you can see that is the normal, but in the second the normal standard is this dotted line, and whenever if there is concavity is there and your this axis, so this is the for the volume. So if your FVC length is preserved but concavity is there, so by the appearance is definitely for the COPD or bronchial asthma or any obstructive airway disease, because there is something abnormal with your FEV1, that is the first second exhalational volume with the ratio of the FVC. So if your FEV1 by FVC ratio is less than 0.7, is that with all this background clinical history, then it's definitely COPD. That's how we diagnose COPD, based on ongoing chronic symptomatic condition and with label spirometry, that you perform spirometry, and even after post bronchodilator we do spirometry in two phases. One is the pre-bronchodilation and the second is post-bronchodilation. That can be salbutamol and even your LAMA drugs also. So if your FEV1 FVC ratio is less than 0.7, that is definitely COPD. So the next important question that has been addressed by the gold guidelines in the last 3 to 4 years, that now we can classify COPD also. So earlier there was just understanding that if patient is smoking and there has been history of cough, breathlessness, expectoration, then it's COPD. But now the gold has come up with new definition, new classification in the form of different etiotypes to label what different type of spectrum of COPD is there. So first, the classical one, there is the smoker related COPD, is the COPD-C, that is associated with the smoking. So C designate to the cigarette. And the second most common in the Indian context, it can be due to any infection. Like in India, what common infection could be, it's the post-TB sequelae. Usually we call it TOPD, the post-tubercular obstructive lung disease, but the gold guidelines, the international guidelines has recommended that it can be labeled as COPD-I. So COPD is not only just with the exposure of the smoking or the cigarette or the BD smoking. Just it's not only with the biomass fuel exposure. It can be associated with the infection. It can be associated with genetic condition like alpha-1 antitrypsin associated COPD. It can be associated due to developmental delay also. So based on this classification table, we can classify COPD also. So the third question, how we classify COPD, how severe COPD is, and what type of treatment that particular COPD patient should be on. So this table is, I guess, is very important, and the most important picture in my entire presentation, that we based on the latest 2025 and the upcoming 2026 gold guideline, we classify COPD in three classes. The COPD group A, COPD group B, and COPD group 3. If your patient is having just subtle breathless, like MMRC1 means the patient is feeling breathless during heavy extraneous activity. And the MMRC2 means the patient is feeling breathlessness during the simple walking only. If your colleague is comfortable in walking and you are feeling breathlessness during the garden walking, then it's MMRC second. So if minimal symptoms are there, then it can be group A and B. But if the symptoms are there and there is tendency of the worsening of symptom, that we call as the COPD exacerbation. So that would be COPD E, COPD group E, and the COPD group E means COPD exacerbation is there, and because of the respiratory symptom worsening, the patient is visiting either outdoor or the IPD. So we will discuss what's the moderate and the severe COPD exacerbation. So the points to remember here are there are three classes: group A, B, E. As far as the Indian population is concerned, I don't think anyone is coming to the OPD if the patient is so much restless, breathless, or the saturation is low. So practically speaking, more than 95% of the Indian COPD patients are fitting into the group E. So that's why we would be highlighting or focusing more on the group E population. So the next question after the classification is how we treat all these group A, B, E and the COPD patient. So the same like the table group A, B, E. So from the last slide you remember that the group A and B are just symptomatic. They are marginally symptomatic. They don't require hospital visit or they don't require any type of hospitalization. So the group A, that is very well controlled and just minimal symptom COPD, can be managed with any type of bronchodilator. Bronchodilator means any type of the short-acting, long-acting beta agonist or any type of the LAMA drug. So patient can be treated with ipratropium, salbutamol, formoterol, any type of the bronchodilator. But group B means the patient is breathlessness during most of the days. That patient requires two types of the bronchodilator. One acting on muscarinic receptors, one acting on beta agonist receptor. So both the LAMA plus LAMA drug would be required for the group B. And the thing that we were discussing, the group E patient, that is the almost 95% of the Indian COPD patient who are coming to the OPD, that is the group E patient. So that patient would be requiring the same drug like the group B, LAMA plus LAMA, two bronchodilator. And if the patient is symptomatic more, like there is tendency that there is repeated hospitalization, the patient's eosinophil is more than 300, so that patient would be started on ICS also. So that comes the triple inhaler. So that come one the LABA, one LAMA and one ICS. So you can see, so these are the long-acting beta agonists which are available like and these are the LAMA drug and these are the ICS drug. So if the patient is fitting into the E group, we can either start on the LABA plus LAMA or LABA plus LAMA plus ICS based on how severe the patient's condition is, how frequently the patient is coming to the OPD or emergency or getting hospitalized. So we are talking about the different type of the inhaler. So the next question is what different type of the molecules are available, what different type of the formulation are available, because over the last 10 years all the formulation, the different brands are available. It's so much confusing even for we as pulmonologists. I can understand the pain behind all the working physicians also, because it's very hard, tough to remember all these available molecules. So we basically classify the inhalers on three types. One is the LAMA, that is the long-acting muscarinic antagonist. So the long-acting means that inhaler would be working for at least 12 to 24 hours. So the available one is the glycopyrronium. So the myth about the glycopyrronium is that since it's the glycopyrronium agent that we remember from the our MBBS time anesthesia practice, the text and the practices, that it will dry up the secretion. But here the most important word or the indication of the glycopyrronium is the bronchodilation. It's not drying up the secretion. It will definitely not plug all your COPD patient secretion. It will definitely bronchodilate the airway, and at the same time it will have some anti-inflammatory tendency also. So that's the LAMA drug. So one is the glycopanium, that is 12-hour and 24-hour working in the different strand. Another one is the tiotropium. Tiotropium is again 24-hour acting, long-acting muscarinic antagonist. One is the latest one is the umiplatinum. That is again for 24 hours. All these three drugs in the LAMA group are available in Indian market. The second thing is the LAMA drug. That was for the muscarinic receptors. About the anticholinergic drugs. The second one is about beta receptor, that is the beta 2 agonist receptor. Since it's a beta selective receptor, beta 2 selective drugs, there is no interaction about the beta 1 agonist nature, there is no significant side effect or risk factor for the cardiac patient. So these drugs are the formoterol, that is twice a day, one is the indacaterol, that is once a day, and one is the salmeterol, again that is the twice a day. All the three drugs are available. Another one are the combination of these drugs. Since in the group A, B, E, we have been talking about the LABA plus LAMA. That is the most standard of the COPD therapy. So the combination of the LABA plus LAMA in the market, in the Indian market, we do have is the formoterol plus glycopanium. That would be twice a day inhaler. It comes in both DPI form and the MDI form. Another one would be indacaterol plus glycopanium. Usually it comes in once a day form. So it's only available in the DPI form. Another one is the vilanterol and the umeclidinium. It's recently proposed and available in Indian market. Again, it comes in once a day dosing. So these are the standard LABA plus LAMA. So you can prescribe your group in stable type of the COPD patient. And if you are considering the addition of the ICS, that we call it the triple combination. And the latest terminology for the triple combination is the SITT. SITT means is the single inhaler triple combination form. So in the single dose inhaler there would be three molecules. One would be LABA, one would be LAMA, and third would be ICS to cover your group E type of the COPD. Okay. So there would be steroid in the form of fluticasone, there would be LAMA in the form of umeclidinium, there would be LABA in the form of vilanterol. So the first formulation is ultra long acting, so only one inhaler once a day, even for your severe COPD patient, is well enough. And the second one you can see is the traditional one, the budesonide, formoterol and the glycopanium. So the dosing would be twice a day. So that's how we classify inhaler based on the dosing duration, the mechanism of action, and the your grouping of the gold guidelines. That would be group A, B, E. So the one important thing about all the inhalers that they work on, one is the beta adrenoreceptor, that is the LABA, muscarinic receptor, that is the LAMA, ICS agonist, that would be the steroid. So the problem with the inhaler that the drug distribution in inhaler is not evenly distributed. There would be some molecule that would be more than 5 microns, means 10 microns. Some molecule that would be 1 to 5 microns, and some would be ultra fine, that would be less than 1 micron. So the most important or the most effective molecule for the lung deposition, for the lung to act, for the COPD to respond is the fine particles. These are the 1 to 5 micron. So we want that inhaler which we are using, which we are prescribing to our patient, should carry these fine 1 to 5 micron diameter size of the particle. So the problem with the traditional inhaler that it only carries 10 to 20% of the level dose. So we are thinking that we are writing 400 of the ICS, but what the patient actively is getting is just 10% or 20, maximum 20 to 30% of that dose. So hardly 40 to 60% of the patient is getting. Why this factor? Because there are multiple factors. How effectively patient is inspiring, how effectively patient is shaking that inhaler, how effectively patient is holding up the breath after taking MDI. So that all these problems, the latest molecule that the AstraZeneca has offered us, the breast Aerosphere technique, that have provided one advanced inhalational technology, that they are providing all these possible drugs, that is the group A, B, C, means LABA, LAMA and the ICS, and all these given possible drugs are combined with a phospholipid porous particle. And the good thing that this porous particle diameter is just 3 micron. That is the standard one that we require, that is 1 to 5. You remember from this slide, the best suitable or the optimal particle what we want for our patient is 1 to 5 micron, and that the latest launched inhaler, they carry this phospholipid porous particle and its diameter is 3 micron. So that's why there could be the optimal size of the particle that we are providing to our patient. So what's the benefit? So it's been on the literature, it's been reported that because of the evenly distribution in the inhaler, because of the adequate size of that porous particle, so the patient would be achieving almost around more than 50% of drug deposition as compared to the traditional one, that is 20 to 30%. So that's the benefit, that's the beauty behind these latest available molecules. So the coming to the treatment strategies, so we were talking about just the role and the action of the inhalers, that is the ICS, LABA, LAMA. So even if the patient is, even after starting all the inhalational or the labs, the patient is still breathless, what the option we do have? So the option can be divided into the base of the patient's the clinical profile. If the patient's lung function is lower side, we diagnose the patient as a case of the chronic bronchitis variant of the COPD based on the HRCT finding. Then the patient can be benefited with the addition of the roflumilast. Roflumilast is basically a drug that is the phosphodiesterase inhibitor, and this drug can further prevent the COPD exacerbation and give some benefit in the dyspnea score also. Another one is the patient.
We are having a wonderful time. We still have to.
Yes.
Wonderful. Very good.
Yes, I will please spend in the next 5 minutes. I will sum up my talk. Okay. So the another possible alternative is the azithromycin. We can add this one also if the patient is having repeated exacerbation for a COPD patient. And another one, the latest available, the biological therapy are also available. So these about the stable patient, COPD patient who are coming to OPD. The next question come up, how we deal with the COPD with the respiratory failure whose saturation is lower side, like the patient is coming to your OPD or the ER room and the patient have been on long-term hypoxic. So the option for these chronic respiratory failure patient, we do have either oxygen therapy or ventilatory support in the form of NIV. So the indication of NIV, if your patient is chronically having higher PCO2, the cutoff value of PCO2 is more than 53, then the patient becomes an indication of long-term NIV. And if there is ongoing hypoxemia is there, means the saturation is less than 88, in the ABG PO2 is less than 50, and the patient is having core pulmonary feature, there is pulmonary hypertension is there, then again it's become an indication of long-term oxygen therapy. So that's how you deal with ongoing respiratory failure in a COPD patient. So these are the standard recommendations based on the gold guidelines. These 6 strategies can modify your patient's future outcome of the COPD. So only the important point to intervene are the adding up of the triple combination drug. Ask your patient to quit the smoking, enroll your patient for the pulmonary rehab, start the patient on long-term oxygen therapy if there is ongoing hypoxemia, start the patient on the NIV if there is ongoing chronic hypercapnia condition, and if there is extensive emphysema is there loculated to any particular part of the lung, then advise your patient for the lung volume reduction surgery. Okay, and there has also been recommendation for the vaccination strategies also, so I am not going into depth. That is how we manage COPD. The standard management strategy for COPD is start the patient on short-acting beta agonist and the muscarinic antagonist, that is the SABA-SAMA drug. Start the patient on steroid also, even if there is risk of infection is there, but the steroid is the magical drug for COPD exacerbations. Start the patient on ongoing antibiotic. If there is any past history of pneumonia, even more than before 5 years, and if there is there prudent expectoration is there. So that how we treat the COPD aggravation, we start on the nebulization of short-acting beta agonist and the muscarinic antagonist on the steroid, on antibiotic, and we at the same time we rule out the possible differential, like there is ongoing pneumothorax is there, pleural effusion is there, arrhythmia is there, heart failure is there. And if the patient is suitable in whichever category, we start the treatment along with. If the patient is requiring NIV, if the patient's pH is lower side, that is less than 7.35, and there is CO2 more than 45, that is the indication of the NIV. And if the patient is disoriented and the patient is not managing on NIV, that is become the indication of invasive mechanical ventilation. So that's how we manage COPD acute aggravation.
Very good.
So that's all from my side. If there is any question, I would ask.
We'll have the questions later. Thank you very much. Please come back.
Try to be very crisp, and next 10 to 15 minutes I'll try to just decipher this dilemma choosing the right biologicals. I think so I'm fortunate enough to be standing here in South Delhi and talking about biologicals, because I think so this is the place where you can talk about biologicals, because these are expensive drugs. Not every patient can afford it. The biggest challenge of writing a biological to an asthma patient is the cost. And I think so if in Delhi you can't prescribe a biological to a patient who is living in South Delhi, is from South Delhi, then I think so you can't prescribe it anywhere. Now these are not the drugs for asthma in which every patient would be requiring them. Every one of us are a practicing physician. We deal with so many asthma patients day in and day out. All of our goal is our patient should be symptom free. He should not visit any emergency. He should not get admitted because of his or her asthma, and they should have a good quality of life. If you see the Indian data, if you see the data which is checking the control of asthma in India, 100% of our asthmatics are uncontrolled asthmatics. If you follow all those European criteria of how good a control of asthma is our country, 100% of our patients are uncontrolled. You prescribe an inhaler to a patient, the patient will simply go home, he will take for 10-15 days and then he will come back. But again, it is not very difficult to manage these patients, because majority of these patients, once you re-prescribe them those same inhalers or those nebulizers, they will be good to go. But there is a significant proportion, some 5% of patients or 10% of patients will come back to you, taken all the possible inhalers, all the medicines, nebulizers, even oral corticosteroids, still having a lot of exacerbation. Here we are going to talk about only those 10% of population. I am not going to tell you about how an inhaler is prescribed, which inhaler is good for asthma, because all of you know, all of you have been practicing that since years together. So we are going to talk about these two entities only, what is difficult to treat asthma and what is true severe asthma. एक अस्थमा का मरीज आता है, inhaler पे है, regularly ले रहा है, 3 times, 4 times a day, nebulizations, still having an uncontrolled symptom is called as uncontrolled asthmatic. That doesn't mean he is a candidate in whom you can prescribe him a drug like biological.
Dr. Saurabh, everyone, there can be just one speaker in the room. If somebody has got something more important, he is welcome to come.
Welcome to. Very good. Very good, sir.
So we are going to talk about these two entities. Now there is an individual who has rhinitis, who has sinusitis, who is morbidly obese, who has severe allergies, who has obstructive sleep apnea, uncontrolled hypertension, hypothyroid. These are individuals in which there are a lot of things which is letting his or her asthma to be uncontrolled. Now these individuals go into your category of difficult to treat asthma. They are not severe asthmatic. They are those individuals who has lot of comorbidity which are not letting their asthma be controlled. So in these individuals, what should we do? Should we prescribe them biologicals? No, that is entirely a wrong thing. We should treat their comorbidity. If they are having GERD, let's treat GERD. If they are having obesity, let's treat obesity. If they are having sleep apnea, rhinosinusitis, nasal polyposis, we should treat them, because if we are treating them properly, majority of these individuals are going to go into that state of controlled asthma, where their asthma is controlled. Even psychiatric comorbidities. A lot of patients nowadays, because of the stress, pollution, the lifestyle which we are living, no exercise, bad diet are into psychiatric comorbidities. So a lot of time you will have patients who will come with complaint of dyspnea but doesn't have actually any wheeze, doesn't have actually any breathlessness, which is contributed by the lung rather than treating them as a candidate for biologicals. Then comes what are severe asthmatic. You have done a detailed analysis of a patient. Despite treating and taking care of all the comorbidity, there will be 5 to 7% of your patients who will land up into a category where their symptoms are not yet controlled. You have given them all those bronchodilators, LABA, LAMA, ICS, Montelukast, fexofenadine, bilastine, desloratadine, every possible thing we have given to them. Despite them, they are exacerbating. They are coming to our emergencies, they are coming to our OPDs, they are coming to our hospitals, using oral corticosteroid over courses over the years. Now you have a diabetic individual in whom you can prescribe him Metrol or you can prescribe him methylprednisolone. If he goes on to that drug, his sugars get haywire. Then the first thing he will decide is to change the doctor because of you, his sugars have gone haywire. Now there is a cardiac patient, there is a thyroid patient, there is a cataract glaucoma patient in whom all these drugs are practically relatively contraindicated. But on the same side, you know that he is wheezing so badly that he might land up in respiratory failure and he might land up in ICU. So can we do something for these patients, especially who are requiring these many kinds of therapy? There comes the role of these molecules which are known as biologicals. Problem with India, especially with pulmonology in India, is we always feel our patients are poor. You ask an oncologist, I don't know if there is an oncologist sitting here or not. Sorry for my words if there is some oncologist sitting here. If a patient goes to them, if a patient requires an immunotherapy, they will prescribe an immunotherapy. Whether that drug costs 2 lakhs, 3 lakhs rupees per month, they will prescribe that drug because they will say our guidelines, NCCN tells that in this particular situation an immunotherapy has to be prescribed. But as soon as you go to a pulmonologist or to a physician, अरे नहीं ये biological कैसे लिख देंगे, ये तो बहुत costly है, the patient is not going to afford. You go to a rheumatologist. If patient requires rituximab, he will prescribe rituximab. He won't say no to that thing because that is the ideal treatment for that individual. And here in asthma also, if there is 5 to 7% of patient who requires these kind of therapies, they should be offered those therapies. We should not decide on our own behalf whether a patient will be buying that molecule or not. If a single exacerbation happens to an individual of asthma, if he gets admitted to a corporate hospital, whatever corporate hospital are there in South Delhi, North Delhi, Faridabad, Gurgaon, every single exacerbation is going to cost him somewhere around 2 or 3 or 4 lakhs rupees. That is the basic cost of a single exacerbation is going to be there, maybe in ICU for 2-3 days in wards, and then all those tests will be done, and then he will land up in his pocket a bill of 4 to 5 lakhs rupees. A single biological, if it is taken and given to a proper patient, can change his entire journey. It can make him exacerbation free. It can make him symptom free. It can even might reduce his requirement of oral corticosteroid, which are sometimes relatively contraindicated in those individuals. Now the big question is, what are the biologicals which are available in India? Although there are 5 or 6 biologicals, in India as of now we have 3 basic biologicals. I'll just go to first that slide. Yeah. So one is omalizumab. Omalizumab came 2008, launched in that time as an anti-allergic biological. We all know asthma has now, there are 2 different phenotypes of asthma. Once we were MBBS, we were told asthma is a disease which starts in early age, has childhood history, allergic history, family history, dermatitis, rhinitis, and then somebody who is wheezing is going to be an allergic asthmatic. So this is the drug which is typically required or typically given to those individuals who are allergic individuals. Maybe childhood asthma where their asthma is being driven by IgE. So there are 2 basic targets which these biologicals are targeting. One is anti-IgE, which is omalizumab, which came in the 2008, and since now we have around 16-17 years of data to it. Second is the molecule which we need to nowadays target is eosinophils. All of us know, we all do a CBC. There are a lot of asthmatics who have high eosinophils in their body. Some will have IgE, some will have eosinophils. That is where comes the role of anti-eosinophilic drugs in these individuals. How these anti-eosinophilic drugs act? They go to those receptors like anti-IL-5. IL-5 is the molecule which drives, or a receptor which drives this eosinophil proliferation and the inflammation which is happening in this asthmatic. So there are now 2 molecules in India itself available. One is mepolizumab and one is Fasenra, which is benralizumab, which can completely take care of the eosinophilic inflammation happening in these individuals. Now comes the question, how should we decide what is IgE, what is eosinophilic? How should we come to know which inflammation is driving the asthma in our patients? A very simple story for that thing. If you have somebody who is very young, coming with a childhood history of asthma, typical history of allergic rhinitis, dermatitis, sinusitis, family history positive, and have a high IgE, these are the individuals which should ideally be given an anti-IgE therapies. Now, since last 5-7 years, what has changed in asthma is there is a concept of late onset asthma. You all must be encountering people who are coming in their age of 40, 50, 60 with symptoms of asthma, never being smokers, never having any past family history, never having allergic history, but still they are asthmatic. And in these individuals you will see their asthma is relatively difficult to control. Usually those who develop asthma at an early or in onset, they are usually good, their asthma is usually controlled, but in those individuals who come at a later age, which are actually a nuisance for you also because their asthma is relatively difficult to control. In these individuals you will find majority of these individuals will have an eosinophilic inflammation going on. And that is where the target molecules like anti-eosinophilic drugs needs to be given. Although this slide looks very dark and looks too much of information, but the easiest way to remember is early onset asthma, allergic asthma, IgE phenotype, give an omalizumab. Late onset asthma, eosinophilic asthma, give a mepolizumab or a benralizumab. Let's see what this drug do. What as a doctor our aim is, our patient should be exacerbation free. Does this molecule do that? Yes, the data clearly says whether you use omalizumab, whether you use mepolizumab, or whether you use benralizumab, all these three molecules, whether they are anti-IgE or whether they are eosinophilic, anti-eosinophilic drugs, all of them lead to reduction in the exacerbation to the tune of even 70%. Now in this slide they are showing that benralizumab, if used for 5 years together, can make a person exacerbation free. What more you want for a patient? A patient who is admitted every year for 3 or 4 times with an exacerbation, landing up into ICUs or HDUs or ward requiring oxygen, having an exacerbation, then the whole 1 month is gone. Exacerbation might remain for 5-7 days, but the effect of that exacerbation is 1 month of uncontrolled asthma, 1 month of uncontrolled sugar, 1 month of uncontrolled blood pressure, high risk of osteoporosis, high risk of cataract, high risk of glaucoma. Do you want this for your patient? No. In that scenario, what you can offer to them if you have appropriately treated them, properly taken care of all the comorbidities, are these drugs which are anti-eosinophilic drugs, especially for those individuals who are elderly. Now a patient will be there who has a lot of cardiac comorbidities. In those individuals, you don't want them to have a single exacerbation because that is going to lead to a lot of mortality in these patients. So for them to prevent their exacerbation is something which is most important. Then comes, can this reduce hospitalization? Can this drug just only prevent exacerbation? The data clearly says, like if this drug benralizumab is used, it has a reduction of mortality to the reduction of hospitality to the tune of 72%. I think so. This is something which is significant for a drug to achieve as far as hospitalization is considered. Now a patient comes to you, you get a PFT. Nowadays everybody is having a PFT. He has a low lung function. The first question the patient asks you is, Doctor साहब दवाई तो शुरू कर रहे हैं, क्या इस दवाई से मेरा lung function improve हो सकता है? That is the first thing which a patient will ask you. And sometimes you are clueless. Okay, will it help him or not? If you see the role of these drugs in those severe asthmatics, you will find that these drugs have shown an improvement in the lung function of these patients also. And Indians understand only maths. They don't understand biology. आप कितना भी समझा लो वो नहीं समझेंगे. वो समझेंगे डॉक्टर साहब 25 था, आपकी दवाई ली, अब 45 हो गया, मतलब आप अच्छे डॉक्टर हो. 25 था, अगली बार है 20% हो गया, मतलब आपने डॉक्टर साहब कुछ काम नहीं किया, अब मैं डॉक्टर बदल रहा हूँ. We are not living in US, UK where you can't change your doctor. आज मुझे दिखाएंगे, कल मैक्स दिखाएंगे, परसों वेदांता दिखाएंगे, because आपने तो 20 के फंक्शन को 19% कर दिया FE1 को. So for them, maths is very important. For them, this kind of lung function is very important. Now comes the most important thing which you can reduce with the help of these drugs is OCS reduction. OCS is, I think so, sold like candies in our country. जो भी पेशेंट आएगा, सर 4 mg मेट्रोल सुबह ले रहे हैं, 4 mg मेट्रोल शाम को ले रहे हैं. क्यों? क्योंकि पिछली बार डॉक्टर साहब ने लिखा था 10 दिन के लिए लेना है, वो तो हमने खुद से शुरू कर दिया. अब आप बताइए आप क्या ले सकते हैं. First important task is to make him understand कि this is not a good drug and inhaler is a good drug. Then he will say डॉक्टर साहब inhaler भी अच्छे से ले रहे हैं, nebulizer भी दिन में 5-5 बार ले रहे हैं, फिर भी मेट्रोल लेना पड़ रहा है. Then is the time we can tell them about the utility of these drugs and the side effect which an oral corticosteroid can cause. And it has been found that drugs like benralizumab, they have a huge potential of decreasing the use of OCS in these individuals. Even 80-25% of these individuals will have a reduction in their OCS dose. The last question which anybody or everybody is asked, will it improve my quality of life? So to tell you our personal experience, we have been working in Amrita since last 3 years using these biologicals. We have roughly 100 patients on biologicals. We have seen patients coming to us every second month getting admitted with us in view of an asthma exacerbation. And now these same individuals are coming every 6 months to 1 year to us just to get our prescription so that they can get this drug reimbursed if they are CGHS, if they are ECHS beneficiaries, or if they are some insurance beneficiaries. They are just coming to us for that thing. Even sometimes they even forget that this patient is under follow-up. Once their name comes up in their OPD list, okay, this patient has come up, and then we suddenly say, "Aap kahan the?" Doctor sahab, zarurat hi nahi padi aapke paas aane ki. We are using this drug and we are doing good. And this is the time when people have also found that not just these drugs have made their life well, even these drugs have somewhat reduced the requirement of ICS in them. The most difficult task of a pulmonologist or a physician is to teach everybody that ICS hai. This is not OCS. This is separate corticosteroid which is to be given in an inhaled format. But now there is Google, now there is ChatGPT. You write any inhaler, whatever you want to write, the first thing they'll ask, "Doctor, isme to steroid hai." They are not worried about that petrol which they are taking 4 mg morning evening, but they are more worried about what? You have written a budesonide which is an inhaled corticosteroid. This might harm us. So is there any drug which can help us in reducing the dose of this molecule? Yes, these molecules have been found, like Prasentra have been found to show a decrease in the dose of ICS as far as these molecules are considered. Just to summarize, if you have a childhood asthma, there are comorbidities like rhinitis, urticaria, food allergies, IgE is high, omalizumab is the drug. The only catch with omalizumab is dose dependent, or omalizumab dose is dependent on weight and Ig values. So if you have extremely high Ig values, you can't use this drug. If you have extreme body weight, you can't use this drug. Then comes Mepoli and Benrali. Mepoli and Benrali, these are anti-eosinophilic molecules. Definitely if you have chronic sinusitis, EGPA, hypereosinophilic syndromes, Mepolizumab is the drug of choice. And if you have nasal polyposis, airway mucus, and hypereosinophilic syndrome, again you can use benralizumab. There is no per se head-to-head trials which have been done, so that was my disclaimer. I won't be able to show you a better result with one drug over the other. But yes, whatever data we have for Mepoli as well as for Benrali, this shows that both drugs work well. Benrali has slight better edge because of the intrinsic property of this drug, that it clears your eosinophil to the tune of 0. If you have even eosinophil 1000, 2 or 3 doses of this drug can make your absolute eosinophil count to a certain 0. So you have to choose wisely. That is the only thing which is there. The question which all of us might ask, or all of us have been asked, which I have already brought in, how to monitor and how long to give. Indians are very fond of asking, "Doctor sahab, dawai to didi, kab tak deni hai, batao." So as of now, the guideline says that you give at least this drug for 4 to 6 months. See the response. You will have 3 kind of patient. One who is not responding. जो respond नहीं कर रहा उसको आपको discontinue नहीं करना पड़ेगा, वो आपके पास आएगा ही. Indians discontinue their drugs themselves. If he comes, then you can discontinue that. If a patient is a super responder, his exacerbation has gone down, his OCS requirement has gone down, his lung function improved, then in that situation you should ideally continue at least for 2 years to this molecule. And if there are intermediate response, or if there are intermediate, then in that situation you can at least give it for 1 year and then reassess and then decide whether you want to switch the molecule or whether you want to pursue some other therapy. Last slide, there are some, I think so, when this slide was given to me, they told me about 2000, but Mukul just now told that there are around 4,000 patients who are on benralizumab in the country, and globally you can see the number of benralizumab or Prasentra injection which are given. So I think so this is the time we all should try to at least prioritize or phenotype our patients of severe asthma, and if there is any patient who can be helped with this modality, we should help them. When I passed out from Cmes, we had only 1 patient on a biological, just single 1 patient who was an Cmes employee. So that time I had a notion that this drug is not going to work. I came out, I joined, we had a very good team, we have a very good team at Amrita. My boss is always pro in writing these biologicals. Now we have a patient full experience of 100 patients. I can tell you 98% of our patients are now controlled asthmatic, just taking maybe their inhalers once or twice in a day, exacerbation free, just with the advent of these molecules. So I think so once we start using it, then only we will believe it. With that, I will finish my presentation. And if there are any questions, I will be happy to answer.
Can you sir please come here? Can you sit on the dais? I'm sure there will be many questions on this very interesting topic. I have opened food for our senior members, Dr. Jasbir, Dr. MPS Gandhi sir. Lalit also leaves early, so I would request him and Dr. Abhavarasha to please take their dinner. But to keep the volume of noise there very low so that we can get on with the question and answer session. Whoever wants to take his dinner now it's not only about the senior people, whoever wants to take their, we are going to have question and answer session for 20 minutes, but you can take your dinner, do not make noise, the dinner can be served on the table itself if you want. Just tell Dr. Deven, he will get you your dinner on your table. I will go to Dr. Sen Gupta, please sit down. I would request Dr. Sen Gupta to please start asking questions about these two important topics.
So, thank you very much for two very wonderful presentations. So, I'm just going to stick, I'm a physician, so I'll stick to the clinical part of it. We see a lot of cases of COAS or COPD and asthma overlap syndrome. So, in such cases, do you have any clinical parameter to decide what component would be COPD or what component would be asthma? Or we just take it as clinically when the patient comes to us in a wheezing condition, fever plus minus, decreased FeV1 and everything. Yeah. So, what's your take on this, sir?
So a very relevant question as far as our country is considered, because a lot of asthmatics in our country continues to smoke also, and then they develop into this entity which is known as COPD-A nowadays, COPD with asthma. So I think, sir, it is the clinical history which tells you about there which component is predominant. If that individual is coming to you with a history that episodically is having symptoms, maybe in a year, twice or thrice, with some kind of change of weather which is triggering on his symptoms, I think so the asthma component is more important for that. If that individual comes telling you that I have a progressive breathlessness, it's increasing, persistent coughing, daily I have too much amount of mucus to expectorate, then is the time I think so his COPD component is predominant. But here comes the most important part. How does it differ if he has a COPD component or an asthma component? I think so more or less now if you see the guidelines of COPD and asthma, all the drugs are used in both the situations. We are using a long-acting beta-2 agonist in both the cases. We are now using inhaled corticosteroid in both the cases, as Dr. Pradeep has shown in his talk, that you have a group E patient in which you are going to use ICS also, LABA also, and nowadays LAMA is also recommended in asthma also. So back there 2013 we were all told you can't prescribe tiotropium to an asthmatic. That was the time. 2014-15 a lot of data came on. Now you can use LABA, now you can use LAMA, now you can use ICS, all the three molecules in asthma also. So practically your treatment choice is going to be more or less triple therapy for both the cases if they are not controlled on their primary therapy. Then comes the next part, biologics. Suppose if I say that asthma component is predominant, he is having eosinophilic inflammation, he should be prescribed a biologic. But what about COPD? If his COPD component is big. So now recently our guidelines of COPD also has approved these biologics if they are having an eosinophilic inflammation in COPD also. So now they are gonna make our lives easier maybe 5 years later, where they are gonna talk about eosinophilic lung disease, eosinophilic obstructive airway disease versus non-eosinophilic.
So only the blood test that you're looking at, or do you go in to do a bronchoscopic biopsy and looking at the
we usually don't do that, sir. Our guidelines is even a blood eosinophil level and a simple pheno, which is fraction of exhaled nitric oxide. That is more than sufficient. Guideline also says you check on sputum, but sputum I don't think so is available. And asking a wheezing patient to go for a bronchoscopy just to check the eosinophil levels is something which our guidelines also don't dictate. So they say if you have an eosinophil level high in blood, or your pheno, which is fraction of exhaled nitric oxide, which is a very simple tool, can give you an eosinophilic inflammation. And very soon the time is going to come when you're going to talk, okay, this patient is eosinophilic bronchitis, this is non-eosinophilic bronchitis, whatever is history, smoking, allergy, family history is going to be there.
So, right now we have glycopyrronium also, which is a relatively new drug. So, how do you place it in the initial assessment when you are giving it? In a clinical condition, I mean, in the routine OPD setting, do you go in for a triple combination or glycopyrronium along with, LABA or something that you would want to do? Is there any kind of a differentiation pattern that you do?
Yes. So now you have three different kinds of patients who come to you. One patient comes to your hospital for a health checkup. He's a smoker throughout his life, now 60-65 years of age, comes, gets a PFT done and found that okay, my PFT is showing some changes of COPD. He's not symptomatic for that thing too much, but his PFT is showing that he's having an element of COPD and he's a smoker, he's of that age in which you develop a COPD. This is an individual in which you should give him just only a single bronchodilator. That is where the role of glycocardium comes in. A single LAMA is more than sufficient for that category A which Dr. Pradeep showed in his talk. Now this same individual or some other...
Basically more in the nebulizer form that we get unfortunately.
Even sir, nowadays we have DPI forms as well as available for this thing. So if somebody is comfortable with the DPI, just a one-day DPI, one single capsule of glycocardium is more than sufficient to take care of their symptoms, whatever they have.
Right.
Now the second category of patients will be who don't exacerbate much, but they comes with too much of symptoms. Their symptom burden is very high. The category B which he showed.
Yeah.
That is the time where you should combine this glycocardium with a long-acting beta-2 agonist. We don't have in India usually long-acting beta-2 agonist in a simple DPI or some kind of a nebulizer. That is very limited in our India. So we have combination of these two molecules together. So you can combine the LABA and LAMA and give them this molecule. If you talk about the category E, which is the exacerbator category, in that category practically every patient is going to require a triple therapy. And if you are practicing at a tertiary care center, majority of your patients will be E. If you are practicing at some clinic, majority of your patients will fit into category kind of B. If you are working as a physician only in a healthcare setting where master health checkups are being done, majority of your patient will be of category A. If you talk about asthma treatment of choice is still ICS and beta-2 agonist. So a combination of this is what is recommended by our standard guidelines for asthma.
So quickly, last two questions. We see combinations of anti-allergics with Montelukast right, left and center. So do they have any kind of a prognostication in asthma? And should we write an anti-allergic separately or in combination, which obviously becomes more expensive? I don't know how much of clinical benefit that would improve.
I think so. This is the most relevant question, sir, as of now in this date of Montelukast and everything submitted. 2022, US has given a black box warning and black FDA warning for use of Montelukast. They are now telling me that this molecule should not be used because it is having so much of neuropsychiatric side effects. 2013, when I was doing my residency from Kanpur, there was a talk by a very famous company on a molecule, Montelukast. They told you can give this molecule throughout the life of a patient if he is allergic or if he is having allergic asthma. That's when I learned कि okay इस दवाई को तो बंद नहीं करना. And when I came into practice, I found और की दवाई बंद होना ये तो नहीं होती. Everybody is taking this molecule.
Even kids.
Even kids. And
right,
that time, that talk also told us it is safe for kids also. Everybody should be given a Montelukast with a combination of some drug. Recently in August, I was invited for a talk where I was told to talk on allergic rhinitis in 2024. I told I am a pulmonologist. How will I talk about allergic rhinitis? Then I searched their literature, then I searched their guidelines. No guideline in ENT tells you that you have to use a combination of Montelukast with a levocetirizine. They only tell you that you have to use maybe a cetirizine, maybe a fexofenadine, maybe a desflurane combination. They are not promoting Montelukast. Last 3 years, what we have done in our practice, we have gradually tapered down the use of these molecules in our patients, and to tell you our own practical experience, 80 to 90% of patients are now maintaining even without those molecules. Yes, if you have too much element of a rhinitis and all those stuff, you can still prescribe them maybe a plain cetirizine or a levocetirizine or a fexofenadine kind of a drug, rather than prescribing them this combination. But again, this is a practice which all of us have to change so that the unnecessary use of this molecule goes down, especially when there is a warning that it causes too much of neuropsychiatric side effects.
So lastly, a very clinical question from my OPD. If I get a patient who has been wheezing, having cough and cold for about a week or so, history of asthma, history of multiple things, and when I do his clinical workup, I know he is suffering from a respiratory infection. Am I wrong in starting him with a triple drug inhaler of the first instance and then maybe, kind of tapering off? Because I want him to have clinical benefit. I don't want to lose the patient also, which is a very practical consideration. Am I wrong, or is it absolutely clinically relevant and medically and ethically relevant to do that?
It's absolutely ethically relevant, sir. If you see the guidelines also, what they recommend SABA with the SAMA to use.
Yeah.
And then they are recommending ICS. So practically they are also recommending in an acute exacerbation you are supposed to use a triple therapy.
Yeah.
So we are not entirely wrong in prescribing our patient a LABA, LAMA and ICS therapy from day one itself, especially when he is having an asthma. Yes, obviously over the period of time once he improves, there is a time when we step down, we might skip off the LAMA and then just continue.
So clinically, the last question, Dr. John wants me to hand over the mic. Clinically speaking, when I see a patient deteriorating, what is the time that I refer to you for benralizumab or any other monoclonal when I am seeing that the patient is not responding? Clinical just dots. I mean, most patients don't want to go in for a PFT, don't want to do anything else. So if I have to look at it clinically that is not responding, is there any kind of a red flag sign that you are looking at when you want me to refer him to you?
Sir, patient on a triple therapy, coming back again and again requiring an OCS use, maybe getting admitted or emergency visits, and you have done everything thoroughly. You have taken care of all the comorbidities. Everything is thorough. The patient is taking his inhaler properly, compliant to the treatment, compliant to the whatever practice, whatever things you have told him. And then still again coming back to you every week or every 2 months with an exacerbation. That is the time when we should phenotype those patients. And I think so you would have already done that. You would have done an eosinophil values, you would have done an IG, maybe just a pheno which is not maybe available everywhere can be done, and then after that you can decide that this patient fits into this category of a severe asthma or he needs an asthma clinic where he can be triaged and can be given a drug like biological or something extra can be done for him.
So thank you so much for your wonderful answer.
I think it will be pertinent to go back to my moderator, Dr. Sunil Kapoor sir, to set the context for both the talks. Dr. Sunil Gupta was in, he actually wanted to ask those questions. So I would request sir, please set the context for the other talk and your take on this talk.
It is a wonderful talk, of course, because we have got something new. The problem is old and it is not going to go away. There are newer causes for it. But then, like I am taking biologicals for my psoriasis. And around 7-8 years ago, I was told to take secukinumab. It was 30,000 rupees every month, subcutaneous. So firstly I thought, then I thought, if it goes into irreversible change, scarring ho jaye, kuch ho jaye, people nahi dawai bhi nahi legi, how will that help? And then Corona came, I didn't get secukinumab, bahar se aati thi. Then now I'm on PKI inhibitors. So, that option came. So these are the things which have come here to stay. And they were a wonderful mechanism, everything is understood. The cost is there, but cost with competition or with newer things will surely come down. That's the marketing part. And thank you for a wonderful talk. It was very, very satisfying.
Thank you both the speakers. There's something that I want to ask you. And I think Dr. Sunil Gupta's question related to that, whether it is sinusitis or it is rhinitis or it is upper respiratory tract infections or it is actually frank airway hyperreactivity, it's a continuum, right? The initial GINA guidelines, they recommended Montelukast. It used to be the drug of choice. And you also mentioned that the American guidelines now say no, that's one drug that should not be used. Can I ask you why? What has changed?
So as per their data, sir, 2022 data, they say there are too much of neuropsychiatric side effects with the use of this Montelukast. So no guideline in allergic rhinitis or sinusitis is saying you that you don't use an antihistaminic. But they are recommending against the use of this molecule because of the neuropsychiatric side effects which are happening. And now if you see the latest GINA guidelines, now they don't recommend that you should be using this Montelukast. They are selectively saying if there is an element of allergic rhinitis, sinusitis which is there, that way this drug might work in those situations, but not for asthma. So for asthma, they are strictly saying you can choose this as an alternative therapy when you have used all your molecules and then still your patient is not controlled, then this drug can be used. I don't know what has happened bad between the US government and the companies who are building this drug. Is there some clash between them or whatever has happened? But now they have given us FDA warnings that this drug should not be used. So we have stopped using it or we have reduced the use to selectively only those who are heavily dependent on them or have a significant element of rhinitis or sinusitis which is not being controlled by the inhaled nasal supplements which are being used.
Right. The second important question which I want you to answer is the continued arguments both in asthma as well as in COPD of infection versus inflammation. And that is why the use of steroids in both the conditions, more in asthma, less in COPD. I want to ask you, what is the hypothesis today and what should we believe? Is it infection or is it inflammation in COPD and asthma?
So if you talk about inhaled corticosteroid asthma, inhaled corticosteroid always have been the drug of choice. So there is no question, even if there is an asthmatic mild, moderate, severe exercise.
So there is an element of underlying inflammation
which has to be given.
Agree?
Yes, I agree.
What about COPD?
So COPD, if you go back to 2015 and 16, there were two trials which were done. One was wisdom trial and one was sunset trial. What this no diabetes, no hypertension, nothing. You yourself will find a difference between a year when you are vaccinated versus if you are not vaccinated. The most common exacerbations in these patients of COPD asthma is due to viral infections. And vaccine have a definite role in preventing these viral exacerbations.
Class 1A?
Yes sir, agreed, totally 1A.
Right. I would come to actually, Dr. Pankul, where are you? Dr. Pankul? Dr. Pankul, are you here? I don't, yeah, I'll come to Dr. I would request, Dr. Pankul, can you please come here? I would request Dr. Pawan Mundra sir to give his conclusion of both the talks. I'm sure you know Dr. Pawan Mundra.
Yes, sir.
He's a legend. Yes, I would request him to please advise us if anything, if there has been a gap anywhere.
Certainly, actually, asthma is very easy to control. Most of the patients remain symptomatic, and there are patients who require frequent, oral steroids. And one of my patients was a doctor. He will start taking steroids, get UTI, and a lot of problems. And once I gave him Ganali, and after first or second dose, he said, "Yeah, Symbicort ka kya karu, zarurat to hai nahi." And he remained alright for nearly 2.5 years. And again, he had a small episode of exacerbation, and which was controlled with a short course steroids. And my question is that one of the patients, after taking the first dose of Ganali, developed some laryngeal edema. He said कि यहाँ सांस लेने में दिक्कत हो रही है, and he had a fever with chills and body aches. Should this patient be given Ganali again, or should be given under cover of steroids?
Sir, since all the biologicals are known to treat for the allergy conditions, but still the major side effect or the only known side effect of all the biologicals is the tendency of different type of the allergy. So there can be rashes, there can be even reported anaphylactic-like reactions also. So only the absolute contraindication or stopping your biological agent is the patient is having anaphylaxis reaction, or being a clinician you are finding that the next dose would be definitely triggering some harmful effect for the patient. So I guess if the patient's asthmatic conditions or the ongoing severe asthma conditions are very well taken care with the biological, the patient should be continued with close monitoring.
That is one part. After the fourth dose, the fifth dose he did not have any symptoms, and he is doing fine. Now, if patient is doing well at 2.5 years, and getting the drug is no problem, how long should he continue? Or suppose you stop at 2 years, what are the chances of relapse?
So that's the most relevant question. The question we answer in all the discussions. So since your patient responded just to second to third dose, we call these patients super responder. So basically we assess the patient response after 6 months or the maximum 1 year. If the patient is becoming, if you are able to reduce the dose of the ICS, if you are reducing the dose of the inhaled corticosteroid, at the end of the 6 months to the 12 year, then we call the patient responder. So you can see that we still require at least 1 year to check the response. So the question, sir, you are asking how long we should continue. That we still don't have any particular answer. Patient should be lifelong on the biological. If there is significant response is there, we can taper down the dose. Like the patient is on twice a month, we can try that the patient can receive the third monthly or the fourth monthly, but the patient should be on ongoing biological therapy because the allergens are there, the tendency is there. The patient should be on biological.
I think now is the time when we are talking about remission. We talk about remission in rheumatological disorders. Now is the time when these guidelines are talking about remission in asthma. And I think so you can achieve a remission only with these drugs which are available, like the biologicals which are available. Very soon we're going to have, all of us are going to have a data on remission with these biologicals. And if there is a drug which can actually remit all your symptoms maybe for years together, then I think so that is the best gift which you can give to an asthmatic. It's very easy in a OPD to write कि inhaler लेना है 3 महीने लो फिर डोज कम करेंगे फिर कम करेंगे. For a patient side it is actually very difficult to keep using that inhaler for longer period of time using oral corticosteroid. And if they are coming up with this concept of remission with the help of these molecules, I think so that is the best blessing or best gift which you can give to your patients.
Dr. Pankaj Mangla, he is at BLK Max. He is the illuminary son of Dr. Pawan Mangla sir, and I'm sure he will have some input into the talks that we have.
It's a very lucid talk, a very nice description on biologics, which was an eye-opener, I hope, for many patients here. We already know about it, we have used it, and we have seen the magical effects. But one thing I want to ask, like some patients, super responder or responders, how you should de-escalate the inhalers just based on symptoms that some patients, most of the patients, they are on high dose ICS. So at what rate, how the ICS, the inhaler dosage, or some patients they may themselves stop it. भाई कोई exacerbation नहीं हो रहा, चलो भाई 2 दिन बंद कर देते हैं, then ऐसे कोई there are hardly any guidelines on this.
So based on all the trials relevant to the biological, there has been no recommendations about how we taper the ICS. There is the trial data, we can make our own recommendation that we can taper off OCS definitely. We can give the patient off OCS trial and we can step down the dose of the ICS. But till today, all the trials, the patients who has been enrolled with the biological, there has been baseline some doses of the ICS. So, as per the recommendations or the standard trials judgment, the patient should be on ICS along with all these biological. Some patients in our own practice also, I remember two patients coming for the biological for us. They are not on any type of the bronchodilator ICS. They are doing fine with the biological therapy, but I don't know the correct answer, how well we are managing them, because as per the data suggests the patient should be on ICS. So in the future, if we have some trial based off ICS versus the biological, we'll get the answer.
And for how long? The longest time your patient is on biologics, like 3 years, 4 years, maximum data?
So as of now, 4 or 5 years we have patients who are on biologics. It all depends on the affordability of it. We are not the one who is going to decide how long he is to take. Obviously, as the guidelines is that you have to continue it for a longer period of time until they come up with the remission data. Okay, after 5 years you can call this thing as a remission and then you can stop it. We are just doing what we are just spacing, increasing the spacing. Every alternate month, maybe every 3 months, maybe every 4 months, depending upon the response. But practically it's like if you have a cancer patient who's on immunotherapy, nobody is going to stop his immunotherapy until there is a complete response, which doesn't happen. So you have to ask the patient that you have to continue this drug. Until he is doing good, you can continue it. Maybe later, after 5 years, you can just stop this drug and see for a symptom free for a period which is biological free. If the patient is doing well on this period also, you can continue it. But if he again relapses back, then I think so these drugs are the things which has to be started. But denying a drug to a patient just on this basis for how long we have to give, I think so we should not be doing that. If he is symptomatic, if he requires that, we should go for that.
Most of the patients, they did not have any exacerbation during the biologic treatment, not even once.
Yes. So that is the beauty of this drug. A patient coming to you 5-6 times in a year, now coming in 3 years, 4 years, having not even a single exacerbation. His life has entirely changed. He's able to do his work, he's able to spend a quality of life. I think so that is the best gift we as a clinician can give to our patients.
Thank you, Dr. Pankul. And Dr. Sengupta has surprised me with his knowledge of respiratory medicine. I always thought he is FRCP diabetes. I'm really impressed.
No. When we were doing a post-graduation, sir, just a quick question. There was a lot of talk about cromolyn, sodium, and there used to be drugs like nedocromil, which used to be in the pipeline, which didn't apparently follow through. So, in the present scenario, do you foresee of return of those kind of drugs? Cromolyn, sodium, antagonist, agonist, blah, blah, blah.
So me and Pradeep both are teaching UG students also as well as PG students also for respiratory medicine. We only use these drugs when we are seeing them or showing them on our slides. I've never seen, as of now, I've never seen these drugs. Yes, I have read about them, but never used them. Yes. Agreed. So as of now, in our guidelines, there is not even a recommendation or even a mention of these drugs.
In those years, Australia and New Zealand used to be one of the biggest prescribers for nedocromil.
I think so the reason for that was the not availability of good inhaled molecules.
True that.
So it's like आपको skin की allergy, आपको skin cream ही लगानी है. So it's like if an allergy of the airway, inflammation of the airway, the drug has to reach airway. Then only other drugs like Moderator, citrazine, nedocromil, and all those drugs has to come into the picture. So the first focus of any physician or a pulmonary physician in the country is to prescribe inhaled molecules. If they are not working, then maybe later on in life, like they are not having use of a lot of doxycycline in our armamentarium. It was now only implemented a few years back again. So maybe there might be a time which comes when you are in need of anti-allergics, when you are able to use these molecules like nedocromil and cromolyn.
Dr. Tulsi sir will have a question.
So, wonderful talks by both the speakers. So, Gina and NICE latest guidelines said to give ICS and OCS as well, especially OCS for 5 days, as good as for giving for 14 days. And not only that, they said they have good biological effects also, reduce inflammation and reduces exacerbations also. Having said that, all patients of bronchial asthma, probably severe bronchial asthma, need to be evaluated for eosinophil counts and FeNO. So, as we know, higher the biomarkers, the more is the response with the biologicals. And if both of them are elevated, probably worse is the progression. But biologicals will improve these conditions when both the markers are very high, biologicals will improve this. So having said that, what about the role of biologicals in low T2 inflammation?
So if you talk about the eosinophil levels, previously they started with 300, now they are 150, now there are even data on these molecules like Fasenra where you can use them even with a 100 value of eosinophils.
Right.
Very soon we are going to have in our country a molecule called as Deciphering. Deciphering is a molecule which doesn't
The only map recommended in low FeNO and low eosinophil count. The only map recommended. Having said that, what about the role of biologicals in pregnancy?
So as of now, sir, there is no contraindication per se for the pregnancy. But yes, obviously the safety of this molecule has to be weighed in view of this one. Omalizumab is the one which is the safest one because we have the maximum amount.
Maximum safety data with the omalizumab is recommended. So talking about comorbidities like atopic dermatitis, chronic rhinosinusitis. So probably when you take into account prescribing biologicals, you take into account whether it will benefit not only lung condition, also the other allergy conditions. Thank you, sir.
Sir, I will not take much time. My first comment is that guidelines. Beta blockers for contraindication for heart failure, now they are the first drug. So the